morning, everybody. How are you today? That's great. That's awesome. By the way, I'm not just saying hello to all of you here, but we're doing this live stream today, and that's just something that we adopted last year. And last year we had some people on there, and this year we have almost triple the amount of people that registered to watch this today. So we're very glad about this, and I just want to thank all of them for being here as well. And I want to thank you all too. For those that do not know by now, my name is Stuart Schlossman, and I too have MS, and we're here because we put together MS Views and News, and we're providing this as a patient advocacy organization to provide something that nobody else is providing, and that is every aspect about multiple sclerosis you can learn from our programs or on our YouTube channel. It's not just about the medications, it's everything that you need to know about MS, and that is what we're bringing to you. Next, as you can see on these screens, we are very fortunate. We have all these different sponsors, and I want to thank them, and I hope that you all could thank them as well. A round of applause, please, for all those that gave us the dollars to do today's program. We have Sanofi, Biogen, Novartis, Teva, Mallinckrodt, Celgene, Genentech, and again, I want to thank them, and I hope that you all appreciate all that they're doing for us, because they're not just doing it for us, but as they're doing for us, it's enabling us to do for all of you. So again, thanks. And also, I want to thank our growing staff. In case you haven't noticed, MS Views and News is growing. I mean, just a few years ago, it was just a few of us. Now there are many of us. And then just a few years ago, we were only doing programs in Florida or in the Southeast United States. We're now doing programs in 23 states. This year, when it comes to a close, and we're not done yet, everybody, we still have 5 programs to do this year. When this year comes to a close, we'll have done 55 programs this year. That's more than ever before. Thank you. So, again, I want to thank our staff. I want to thank our sponsors. And next, of course, I want to thank all of you, because if you don't come to our programs, then we can't do these things and we can't educate anybody. So, again, I want to thank you all. You know, there's the Q&A today is going to be a little bit different. The Q&A, we're going to have our presenters here, and then we're also doing this for the live stream audience. And this is something that I do every year, and it's very fortunate for those that are on live stream. All right? This is my personal cell phone number. I'm only taking texts from numbers that call long distance. All right? Anybody has a question for our clinician panel, they can call 954-684-1683. And again, I'm only taking, last year somebody fooled me and was dialing in from 786. That's not going to happen. This is so that way those that are on live stream will be able to ask their questions. Again, the number is 954-684-1683, and it's only for today. And if you use it after today, I have to come after you. No, I'm joking. All right. So next up, how many caregivers do we have in the room? How many caregivers? Thank you, caregivers. Everybody give those caregivers a round of applause. They need to be recognized for everything that they are doing. Awesome, thank you. Today's program, let's move things along quickly. We're going to have Dr. Negroski. We're going to have Megan Weigel. Something special about Megan Weigel today. Megan Weigel is a nurse practitioner. She's also president of the International Organization of MSRNs, and her baby is sick this week. And she couldn't be here. So guess what we're doing? Technology. She's going to be in on GoToMeetings, and she'll be seen at the top of the screen doing her presentation for all of you to hear. And the live stream audience will be able to see her as well. That's awesome, isn't it? I think it is. So Megan will be with us, and then she'll also be here for the Q&A. So if you have a question specifically for Megan, you'll just have to say, this is for Megan, and Megan will be able to answer you because she'll be able to hear you through the microphones that will be put up to you. All right? And then after Megan's presentation and before the Q&A, we have Dr. Aaron Boster. Dr. Aaron Boster came down from Ohio. You'll know more about him later on. Then we'll have Jeff do some stretching. We'll get into the Q&A. Jeff will do more stretching. Then we'll have Dr. Konitzer, who's a psychologist who's coming in from Orlando. And then the last speaker of the day, sexology. Can't wait to hear that one, all right? All right. All right, so our next presenter will be Dr. Donald Negroski, and he is here. He came in from Sarasota. I'm going to read your intro in a moment. And so, fortunately, he gave me a short intro. So Dr. Negroski has been a neurologist for 32 years and is the medical director of the MS Center of Sarasota. He is also clinical assistant professor at Florida State University. Dr. Negroski has completed his fellowship in neurology at the Cleveland Clinic Foundation in Cleveland, Ohio. He has made numerous contributions to clinical trials and has been an expert presenter nationally and internationally in the field of multiple sclerosis. And I also want to thank Dr. Negroski for being here today. Thank you.
Thanks, Stu. Okay, thanks. So good morning. How's everyone? I am so relaxed, and I hope I don't fall off this stage because Tony did such a great job. Thank you so much. My task is a unique one. It's a little bit different than the typical MS lecture. I'm going to get into healthcare systems. And the title is Improving Your Engagement and Communication with Your Healthcare Team and Learning to Access the Care that you need in Shifting Models of Healthcare. So the key word that I picked up in that title is Shifting Models of Healthcare, and I'm going to comment on that. And patient self-advocacy through knowledge and self-reliance. So my goal today is for each and every one of you to come away with maybe 3 things that you haven't thought about before about your journey in MS, because this directly affects MS patients and the care partners of MS patients. So shifting models of healthcare. So what does that mean? So when I was given this task, I keyed on shifting. So shifting means some legacy effects. You have to go through history. So what I'm going to do in order to reach those goals, I'm going to talk about the evolution of medical records and the transition to electronic medical records. Electronic medical records. Who in the room likes electronic medical records when you see their doctor? So 1, 2, 3. How many people like the old-fashioned way with charts and so it's kind of split. It's kind of split. So, I'm going to go through why there is an evolution of electronic medical records and potentially how this will actually empower you to interact with your physician on a more easier basis. So that may translate into improvement in patient engagement. So evolution of medical records, it started actually with the stimulus package back in 1990 or 2008. It was the American Recovery and Investment Act, so-called stimulus package. So when you look at the stimulus package, it was signed into law in February of 2009, and it was about $787 billion in funds for economic development. Remember the stimulus package back in 2009? That was the evolution of the electronic medical system of healthcare. So part of the stimulus package was $25 billion to set up and promote and expand the adoption of a nationwide network of electronic health records. $25 billion. So out of the $25 billion, there is $18 billion set aside for hospitals and physicians in order for them to kind of adopt all the technology needed. You needed to buy computers, you needed to buy software, you needed to do a lot of stuff. And that began in 2012. So the Health Information Technology Act was promoted to put meaningful use. You couldn't have electronic medical records unless there was some kind of meaningful use of the records. So part of it, the incentives for physicians and hospitals to use electronic medical records was at $18 billion for equipment and training in order for us to meaningfully use EHR systems or face a penalty. So now if a physician or a hospital doesn't have electronic medical records, they're penalized. So that was the start of getting away from the paper trail to the electronic trail. So what is meaningful use? The question is that like my chart type of thing? And so the answer is yes. So in order to use electronic medical records, there must be a reason to use them, right? So hopefully it would improve quality, safety, efficiency in offices, right? Engage patients and families on a communication. That gets into shared decision making, which I'll cover before. Hopefully improve coordination of care both individually and across the country, and maintain the privacy of information to guard your medical records. As a result, the outcome expected is that it will improve clinical outcomes, improve not only patient outcomes, but maybe outcomes of populations throughout the United States, empower the individual patients and their care partners in delivery of care, and more robust system research in healthcare systems, how it is delivered. So that's kind of the story behind meaningful use. So there are some impacts on the provider as well as the patient and their care partners. So the provider has to enter all the records electronically. We have to enter lab, we have to enter prescriptions, diagnostic things, referrals for other consultants. We have to perform what's called a medication reconciliation, which means when you go to your doctor's office, he or she looks at your whole list of medications and updates them from other physicians, which are important. Ability for the patient to view and download their records. And then embedded in this is a reason why doctors should do this. And hopefully, going forward, it leads to what's called best practice parameters. And that's been developed by national organizations, how you should treat a patient with a certain diagnosis. Down the road, hopefully, not only heart disease, but neurological disorders such as MS, orthopedic disorders, anywhere from broken bones to a hangnail. So, there's all these forms that the physicians are going to be graded on, based on not if you do the stuff, but if it improves the outcome of a patient. And in MS, the Academy of Neurology back a couple years ago put together a task force to look at this for MS patients. So they invited a few neurologists, but they invited physical therapists, occupational therapists, speech therapists, all kinds of people, and they came up with a 45-page document of things that we should look for in MS patients. 45 pages. So it's kind of hard to with a 15-minute follow-up that you have in a patient for MS is to cover 45 pages of these things that we're supposed to document, right? Because you're there for one reason, I'm there to discuss your reason, but then at the same time, we're judged if we hit all these targets. So it's kind of, it's a challenge. So starting in 2018, reimbursement to physicians and hospitals are going to be based on quality scores. Not so much if you just see the patient. You have to make sure that your quality scores are high. From a patient standpoint, there's some impacts. There's patient portals, as you pointed out, right? Secure messaging for your physicians, prescription, and hopefully that will improve engagement between patients and their caregivers. Not just phone calls. You can go online and do things. There are some changes. When I was in medical school back in, when was that? Maybe the 80s or so? No, wait a minute, maybe 70s. early 70s, whatever. Things have changed because we were taught a paternalistic approach to medicine. The physician was like the captain of the ship. We're supposed to know everything. We're supposed to dictate the best principles to the patient and their care partners, right? And that has shifted. The paradigm has shifted in healthcare to more of a shared decision-making process. So physicians, especially those that have been trained several decades ago, it's a different mindset. The newer docs coming out are kind of up to speed a little bit. So this allows for shared decision-making, or SDM. So it's between the patient and the doctor. But what's missing, in my opinion, in this whole scenario is a new thing, a new player in the relationship. What do you think that new player is? What's that? Insurance. Insurance and insurance companies. So the new player is insurance companies as they act through what's called pharmacy benefit management companies, or PBMs. PBMs. So you're going to hear all these terms. So the PBMs and insurance companies are also a player in the thing. It has to do with copays, if the drug's on the formulary, what tier it is, if you have to use X drug before you use Y drug. And that's not talked about a lot in the shared decision making. What's talked about is the relationship between me and my patient. So there are the definition of a true shared decision-making process is that we work together with patients to make decisions and select tests, treatments, and options based on clinical evidence that I was taught by looking at MS studies and drug reports and safety and efficacy and all that stuff, right? And weigh that with the risk and benefits and the patient's preferences and values. So the patient's preferences and values are new. It's a new player in this thing, and I think it's a good thing. Because the worst thing I can do is tell a MS patient that I think you should be on this drug and this drug only, and it may be completely different than what you think, right? And what's going to happen? You're going to go home and agree with me in the office, but on the way home in the car, you're going to think, well, I'm not going to listen to what he said because I don't agree with that. And then you're not going to take the medication. So compliance goes down, and it's a lose-lose situation. So the patient's values have to be taken care of. So for physicians, in order to make a shared decision-making process, it stands for seek your patient's participation, that's S. H is help your patient explore and compare treatment options. Access your patient's values and preferences, and that's what's important for my patients, to share with me their values and their preferences. Reach a decision between the patient and myself, and then more importantly, after the decision is made, going forward, evaluate the outcome of the decision to see if it's the right thing. So that brings the patient's responsibility at a higher level, because you have to know the treatments and you have to know the decisions. So forums like this are important because the speakers and my colleagues that follow me are going to go through some of the treatments and some of the decisions that have to be made. And I'm glad you're here because you want to be informed and know about your decisions. And hopefully by putting all these things together, it's going to improve patient compliance and outcomes. There are barriers, as I mentioned, the PBMs and insurance companies, because of tiered and formulary and copays. So the patient and I can reach a decision that I want this patient to be on this drug for their disease-modifying therapies. And we went back and forth, and we got all the decisions up, right? But what happened? You put the order in, and it's not covered. Or you have to use this drug before you use that drug. And it's very frustrating. And then the patient calls me up and saying that you didn't put the form in properly, and then, you know, and it just takes time. So that's a barrier. The time with the patient, you know, you may only have 15 minutes or 20 minutes for a visit, for a follow-up visit, or a half an hour or whatever. But then if we have all these kind of things that we have to document in the computer, there's no time to talk to the patient about what's important for that visit. Because how many times, sometimes when I go to my doctor, I don't even see their eyes because they're behind the screen a little bit, and, you know, they're typing away, and you know, so they can hit all these goals. So, you know, you have to be informed, and there are sources of information. So the information comes from different sources that are reputable, and for physicians, the sources that we use are informative or authoritative sources. With MS drugs, it's clinical treatments and research, placebo-controlled double-blind studies of hundreds, if not thousands, of patients with the drug to see if the drug is beneficial. And we look at side effects, and if it is beneficial, that's all listed in percentages, and the side effects are listed in percentages. So those are kind of authoritative things that we use to hopefully make a decision. And then there's informative sources, which are direct-to-consumer marketing ads on TV, and brochures that the doctor gives you when you leave, usually from pharmaceutical companies. And then there are forms, not written forms, but like on the internet, and forms of chat groups and things like that. And then there's anecdotal ideas, like your neighbor who has MS was placed on this drug and they're doing remarkably well, and you want the same drug because you think that if you go on that drug, you're going to do remarkably well. But with MS, as you know, each patient is individual. What works on one patient may not work on another. So the physician looks at these authoritative things. Patients look at kind of everything. And we all come together with hopefully a benefit. So that puts, as I mentioned, reason that you're here to learn, to help communicate your wishes to the physicians. And the physician has to be comfortable about listening to what you say. And if a physician is not comfortable about listening to what you say, then you're out of the equation, and that's not good. So you have to have a good rapport with your physician. It has to be a two-way street. Just a quick thing about ads, or not ads, aids, right? Decision aids. Patient decision aid, when I was researching this, I was interested to find out that there is a international patient decision aid standard collaboration. How about that? There's groups for everything. And so these patient decision aids, there's a collaboration internationally what should be in these aids. So specifically with MS, has anyone went on the American Academy of Neurology website and looked at the MS decision aid? Do I see a show of hands? Anyone? One? One out of a few hundred people? One. So that exists. So this is just a screenshot of the decision aid. So 5 questions for patients starting a disease-modifying therapy for MS, right? 5 questions, list the drugs, and then it lists some other questions that you can handwrite before you go into your doctor's office to get the best information possible to make the decision. So I would encourage you to go on that website and kind of just look what's there. I think that's beneficial. So let's kind of finish up with a case study. This is a hypothetical case, but doctors that treat MS patients run across this all the time. A 40-year-old female that had MS for about 10 years, and she was placed on an injectable treatment for MS. But she got a promotion, and her promotion requires her to travel throughout the United States frequently, every few days on a plane. And so as a result, I mean, she's doing relatively well with her injectable therapy, but she misses dosages now. She comes in and says, "Doc, I'm missing my shots because it's not practical." So she wants to go on a pill. Kind of makes sense. That's her decision. So we sit down and go over the options. We consider that the drug X may not be interchangeable with drug Y. We go over the risk and benefits, and that everyone does. It's complex. Patient selection and drug selection should go hand in hand. And some patients shouldn't be on certain drugs, some patients should. So what happens, there's some trade-offs. The cost of the drug, tiers, patient preferences, and what happens. So the insurance company, we decide to go on an oral agent, but the insurance company says you have to try another injectable first, which is not why she wants to change. So if you go on the injectable and the patient can't tolerate the injectable, then you can go on an oral agent, but then they said you can't go on the one that you decided. You have to go on this one, another one first before you go on the other one. So that happens, if you talk to your neurologist, that probably happens a lot. And it requires staff time and phone calls and things like that. So there are different considerations. So when we look at MS drugs, we look at the impact of monitoring of the drug. The other presenters will kind of get into this. Cost of the medication, frequency and method of administration, how the drug works compared to other drugs. Patients want to know about kind of side effects. Some patients want the safest drug on the market, even though it may not be the most efficacious for their MS. Some of my patients want the strongest drug that may have very serious but infrequent side effects. So each person is different. There's no right or wrong drug for each person. So in conclusion, what I try to do is kind of walk you through this shift in healthcare. It started with the stimulus package, electronic medical records, and then the use of all this data that they collected many years ago, and to try to morph it into quality issues and quality of care, but at the same time increase the patient's decision-making in their own treatment, which is a good thing. There are new players that are thrown in here that makes it difficult for patients and physicians to kind of come up with the right thing. So there's another player that should be addressed. So hopefully by shared decision-making, we can make an improved outcome in terms of treating MS patients. So with that, I want to close, and I want to remind you that my goal before I started is to have you come away with 3 things about your journey in MS that may be new to you, little pearls that you picked up, and if I've done that, I've done my job, and I want to thank you for your kind attention. Thank you.
So questions for Dr. Negroski will be asked later on when we get into the Q&A, okay? But again, thank you. So next, as our trial basis goes, this is the first time we'll be doing this from afar, and you do have Megan up on the screen, everybody, way up at the top of the screen. Okay, and Megan Weigel, let me just tell you something about her. Megan is the Doctor of Nursing Practice. She's got the degree in Doctor of Nursing Practice. She's been a nurse practitioner for over 16 years. Her affiliations, she's president of the International Organization of MS Nurses, co-founder of the OMS Yoga, member of Health Advisory Committee, North Florida chapter of National MS Society. She's the recipient of the Hope Award, North Florida chapter of the National MS Society. Megan is a fellow in integrative medicine at the University of Arizona. And again, let's welcome Megan. Everybody, thank you for doing this today. It's your turn, Megan.
Hi, everybody. Good morning. I appreciate, first of all, so much Stu and Bill and Jennifer and everybody working with me to get me live with you guys. Some of you may know I have a 9-month-old baby, and he has decided to have hand, foot, and mouth and an ear infection this week. So it's been a challenge, but we've been really lucky to be able to do this. Sometimes technology is a menace, and many times it's wonderful, and this is one of those wonderful times. It's very odd that I can't see you, and I feel like I'm smiling into a little window. So I appreciate you working with me, and we'll get going because we've got a short amount of time to talk about some very important things. Going to talk about the unpredictable part of living with multiple sclerosis, of which you guys are really familiar, and also how you can create some predictability in your life through wellness strategies. So the objectives of today, I'm going to skip over the basics of MS. I'm sure Dr. Negroski did a great job doing that with you. I'm going to discuss relapses and pseudo-relapses, as well as common symptoms in MS and their management, and then move on to discussing lifestyle issues that are important to living your best life with MS. MS basics, you guys could give this talk. Like I said, I'll skip over this slide. And we'll move on to one of the most unpredictable things in MS, and that is relapse and pseudo-relapse. I know that many of you probably worry about when you will have a relapse or if you will ever have another one. Will you completely recover from it? How will it be treated? Will your life change afterwards? So a relapse is a new neurological symptom or increased severity of an old neurological symptom that lasts longer than 24 to 48 hours. And it can't be explained by something else. So you don't have a concurrent infection. You haven't been at Disney World for 3 days with your children. You don't have a fever. You're not overly fatigued or overly stressed. And how do we treat a relapse? Well, we offer medication to shorten the duration of a relapse. And that medication is usually steroids or adrenocorticotropin hormone. So steroids can be given IV or they can be taken very high dose orally. ACTH can be given subcutaneously or in the muscle. Very rarely we'll use plasma exchange. This is reserved for severe relapses, not responsive to steroids. And some people use IVIG less frequently for others who are not responsive to steroids. I think it's important for people to understand that steroids shorten the duration of a relapse. They don't change your recovery potential. So I know I've had some people living with MS say to me, if only I'd taken steroids for that bad relapse. And I try to reassure them, because many people don't tolerate steroids or even ACTH well due to side effects, that taking steroids makes you get better faster, but how better you're going to get at the end of your relapse is the same, with or without treating with steroids. So that leads me to non-pharmacological ways that we manage relapses that are equally as important, and those are things like physical and occupational therapy, speech therapy if a relapse has affected your speech or swallowing, and also developing exercise programs. And this all relates to the severity of the relapse and how it has affected you. So if a relapse has affected your walking or your balance or your strength or your eye movements, you might need some rehabilitation therapy to get you back on track. Additionally, if you have increased numbness or pain or discomfort, then adjustment of medications for your symptoms can happen. So what's a pseudo-relapse? How do you know the difference? A pseudo relapse is an increase in severity of a neurological symptom, and it's caused by something else. So it's caused by that infection like UTI or flu or cold or bronchitis or fever. It's caused by over-exercise. It's caused by increased stress or fatigue. UTIs are usually the most common form of pseudo-relapse in MS because people with MS are more prone to them, and they don't necessarily cause the typical urinary tract symptoms. So an example of a pseudo-relapse would be increased spasticity or worsening of vision in an eye that you had optic neuritis affected by, and those things would occur in the setting of a UTI. And how do we treat the pseudo-relapse? Well, we treat the underlying condition. So if you have a bacterial infection that needs antibiotics, we treat you with antibiotics. If you're tired, we tell you to rest. We can adjust symptomatic medications if other things are occurring. And we also tell you to keep cool because sometimes pseudo-relapses are related to prolonged heat exposure. Same as with relapse, if a pseudo-relapse has really knocked you down, then we may prescribe rehabilitation therapy as well. So let's move on to some more unpredictable stuff in MS, and these are MS symptoms. And MS symptoms typically fluctuate in MS, although they may be constant but fluctuating in severity. And they can be primary symptoms that are directly related to the location of a lesion, or they can be secondary symptoms, which means they occur as a result of something that MS has done. And an example would be falling because you have weakness or balance problems, or they can be tertiary. And tertiary symptoms are behavioral symptoms or emotional symptoms that are caused by just having a chronic, unpredictable condition. And so an example of a tertiary symptom would be loss of a job, or loss of a relationship. The most common primary symptoms in MS are fatigue, cognitive issues, bowel and bladder disturbance, spasticity, altered mobility, visual changes, altered sensation, pain, and depression or anxiety. Secondary symptoms are things like infections, falls, skin breakdown, injuries, contractures, decreased ability to perform your daily activities. I'd also add onto this list orthopedic issues. And then tertiary symptoms, again, are things like I mentioned previously, additionally, social isolation and loss of self-esteem. And our goals with symptom management are to eliminate or reduce symptoms that impair your functional abilities so that we can ultimately improve your quality of life and then avoid secondary complications. So I'll take walking, for example. So walking definitely improves your function, or impairs your function. And if we improve your walking, we improve your quality of life. And if we improve your walking, we avoid secondary complications like knee arthritis, back pain. So you can see that this is really a multifactorial ball of wax that we use with symptom management. And symptom management is very targeted. It's very individualized. And in my practice, I like to ask you what your goals are and how you best like to treat problems. Do you like to treat them pharmacologically, non-pharmacologically, or in combination? It's really important that we get at symptoms quickly because as you can see here with this slide, it is a growing ball of string. And it's often what comes first, the chicken or the egg? Are you depressed because you're tired, or you're tired because you're depressed? Do you have spasticity because you're constipated, or do you have spasticity because you haven't been exercising? So we really like to develop a good whole person plan that treats your symptom. Let's talk about a few of these symptoms. Most common disabling symptom of MS is fatigue. It can occur early and it's not related to physical disability. Our first go-to line of thought is MS causing the fatigue? Because it could be something else. It could be a thyroid disorder, a vitamin deficiency, anemias, a low-grade infection, a mood disorder, or even a side effect from other medications that you take. We also have to consider sleep disorders. So how do we treat fatigue without medicine? We prescribe exercise. Yes, you heard it. Exercise actually improves fatigue. We prescribe cooling. So even if it's not a hot day, even if you're in a gym walking on a treadmill for 10 minutes, your core body temperature still increases and can cause fatigue. So we'd like you to stay We prescribe rehab, and we prescribe stress management. Stress management is helpful not just for physical fatigue, but also for cognitive fatigue that you have. Like you can't think straight. You notice that when you're doing a million things at once, your thinking is definitely foggy. Stress management can be really helpful. And then pharmacologically, we use wake-promoting agents like modafinil or desmodafinil. We use stimulants such as amphetamines, and we use antidepressants. Also, sometimes amantadine can be used. Spasticity is often described as tightness, pulling, heaviness, or squeezing sensations in the arms, around the chest or abdomen, and around the legs. It limits mobility, and it also expends energy, and it's painful, as many of you, I'm sure, know. So without medication, we can manage spasticity, again, with exercise. You're going to see exercise a lot on these slides. You can manage it with physical therapy, with bracing, and with assistive devices. For example, using a walker or a cane. Pharmacologically, we use muscle relaxants. We use anti-seizure medications. Botox can be injected locally into certain muscles in the arms or legs to help with spasticity. And if medication is maxed out to a tolerable level, then you can consider a trial of intrathecal baclofen and placement of the baclofen pump. Bladder dysfunction is a double-edged sword, and we'll talk about bowel dysfunction on the next slide, and they really go hand in hand. So in MS, bladder dysfunction is usually the inability to store, to empty, or a combination of the two, and oftentimes it varies back and forth. So for example, someone will say, Megan, I can't hold my urine. And then 2 months later, they're saying, boy, you know, I'm not incontinent anymore, but it sure does feel like I don't empty my bladder all the way. So much like any other symptom of MS, it can come and go. Non-pharmacologically, there are a lot of things that you can do to manage bladder dysfunction, particularly if it's really early on. And these are things like avoiding bladder irritants. The most common bladder irritants are caffeine, alcohol, and artificial sweeteners. So if you are putting Splenda in your coffee, stop. Drink decaf. Managing constipation, drinking enough water in larger amounts throughout the day, timed voiding, exercise, pelvic floor rehab can help. Pharmacologically, the medication depends on the type of the problem, and also Botox can be injected. Bowel dysfunction is usually constipation, less likely diarrhea. Fecal incontinence is rare, but happens. And I'll tell you what, folks, right here now, you're going to have to drink more water. It's going to help your bowels and your bladder. You need to eat a healthy diet, and you need to eat more fiber. Avoid depending on enemas. Okay, I just sped up because they told me I had 9 minutes left, and it's been corrected to 19. I was a little freaked out. Yay, we can talk about bowels for a little longer. Avoid depending on enemas and suppositories, as they can damage the rectal wall and the muscle, and they can actually make your problem worse. And once this has happened, there is no going back. So please, before you start using these methods of trying to amend constipation, talk to your healthcare provider. Pharmacologically, fiber supplements can be helpful, but only if you're drinking enough water. Stool softeners can be helpful, and so can bowel stimulants. Now, many people with MS also have GI issues like irritable bowel syndrome or autoimmune disease of the bowel or inflammatory disease of the bowel. So anytime your bowel habits change, talk to your healthcare provider so that the best management plan can be remedied for you. Let's talk a little bit about pain. Pain in MS is acute or chronic. Acute pain is primary, which means it's usually related to a lesion in the brain or spinal cord. And this is something like trigeminal neuralgia, which can become chronic. Optic neuritis or Lermite sign, which is that clocky sensation when you take your chin down to your chest. Lermite sign can also be a chronic problem. Other chronic problems include dysesthesias, which are your pins and needles and burning sensations, musculoskeletal pain, so back pain, neck pain, knee pain, joint pain, and spasticity. Here comes exercise again. Non-pharmacologic management of pain includes exercise because exercise generates endogenous or your own endorphins, and endorphins help decrease pain. Stretching is also very helpful. Relaxation techniques like guided imagery have been proven to be very helpful in pain. Also cooling, and then physical and occupational therapy. A great resource for guided imagery that you may want to write down is via Kaiser Permanente, which is a big healthcare system out west. If you Google Kaiser, Kaiser podcast, the first link that pops up is a link to about 30 free guided imagery podcasts that you can listen to. They're very specific. They're very wonderful. They don't require you to know how to meditate, and they are incredibly helpful for pain. Pharmacologically, we use anti-seizure medications, antidepressants, topical medications, and interventional therapies. Unfortunately, opiates, I would say unfortunately or fortunately in this day and age, opiates don't really help for neuropathic pain. I think of that as a good thing because opiates also cause many other problems in MS, like worsening urinary dysfunction and constipation. So we really try to manage pain from two different levels. One is the mind-body level, and the other one is the medication level using less harmful medications. Which brings me to more about mind-body. In multiple sclerosis, high rates of depression occur, and the incidence of suicide is markedly higher. You can read about the symptoms of depression here. You don't always have to feel melancholy to meet the criteria for diagnosing depression. It may be that you've lost interest in things. It may be that you feel hopeless. It may be that your sex drive is low or that your energy level is low. And again, like with fatigue, we have to rule out other causes of depression, like thyroid disorders, vitamin deficiencies, and medication side effects. And depression is something that should be managed non-pharmacologically and pharmacologically. So non-pharmacologically, psychotherapy, exercise, actually improving your diet can improve your mood, and finding social support. Pharmacologically, depression can be helped with antidepressants and sometimes with certain supplements that should be very carefully managed by someone who knows what they're doing. Cognitive dysfunction like fatigue can occur early in the disease and is unrelated to physical disability. It can be subtle. Again, with cognitive dysfunction, we rule out other causes, and a primary one here would be a sleep disorder, also medication side effects. Non-pharmacologically, cognitive rehab, occupational therapy to help you with organizing, use of reminders, educating your family that there may be things that they can help with, playing brain games and learning new things, like learning how to play an instrument, learning a new language, learning a new skill can be helpful for cognition. Pharmacologically, sometimes stimulants and antidepressants can help cognition. Medications for Alzheimer's dementia are not helpful, so these things we don't typically recommend. So let's move on to adding some predictability and living a life of wellness when you have multiple sclerosis. I'm going to talk about two definitions here. The first is the definition of health. And this definition was created by the World Health Organization. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease. So you can be healthy in spite of having a chronic illness. The definition of wellness is a little bit more specific, and I like this. Wellness is the optimal state of health of individuals and groups. There are two focal concerns. One is the realization of the fullest potential of an individual, physically, psychologically, socially, spiritually, and economically. And it's also the fulfillment of one's expectations in the family, community, place of worship, workplace, and other settings. So actually, I would argue that you can be completely without disease and be unwell. And I hope that you can see how this happens, how you can be free of disease and be unwell, and how you can have chronic illnesses and still live in a state of health and wellness. Modifiable lifestyle factors that affect MS include nutrition, sleep, Exercise, smoking behavior, vitamin D exposure, hydration, taking care of your general health, and stress. And look at that, folks. That's a lot that you are in control of that can help you feel better every day. Let's talk about nutrition. MS diets. Google it, you get more than 2 million hits. So how do you make sense of it all? The bottom line, in my opinion, is that unless you are truly allergic to something or have a medical condition that mandates it, it is not recommended to eliminate major healthy food groups from your diet. So what does that mean? Well, let's talk about some of the most popular MS diets. The Swank diet bans all dairy, all gluten, legumes, and saturated fat from animal products. There's a high incidence of unsaturated fats from fish and fish oils. And in its original form, it's extreme. It's easier to adapt if you modify it. The Gold Coast cure is now touted for autoimmune and inflammatory conditions in general. It's gluten-free, low-fat, high in omega-3s. And then the Walls diet, or a paleo diet, is kind of a minimalist Walls diet, is also pretty hard to implement in its purest form. It's about 9 cups of vegetables per day, wild fish, grass-fed meat, organ meats, and sea vegetables. Anecdotally, people following these diets, even in modified forms, feel better. Rigorous scientific research has not been completed to tell us whether or not they modify your disease, and study findings are not often replicated. So here's my 2 cents. Follow a Mediterranean diet. You can also follow an anti-inflammatory diet. If you, quote, Google that, you'll find excellent information about it. Make your diet bright in color, low in fat, limited in saturated fats, eat whole, real foods, consume salt, alcohol, and sugar in moderation, increase your intake of omega-3s through fish that is high in them. If you are not vegetarian, limit your consumption of animal protein to no more than 10% of your daily intake. And if you're eating animal protein, make sure that it's grass-fed, grass-finished, hormone-free, and antibiotic-free. Eat real foods. Americans have gotten fatter on the fat-free food crisis, or I'm going to call it a crisis, fat-free food era. Americans are going to get fatter on the gluten-free food era, because when you go to buy packaged gluten-free foods, they are so high in sugar. Eat real food. Shop around the perimeter of your grocery store and try to buy local. Farmers markets are everywhere these days. Really just access what's in your community. See if there's a vegetable co-op available. Sometimes these will even deliver to your door. Exercise. You heard exercise a lot. It's associated with decreased weakness, decreased fatigue, better mood, improved bowel and bladder function. And depending on the type, there's also an association between improvement in spasticity and pain. So basically, I tell people to play every day. Find something that you like to do that works for you. It does not have to be strenuous. It has to make your heart feel good, and it has to make your heart beat a little bit faster. Exercise during your best time of day, and even break up your exercise times if that's easiest for you. Consider when you take medication, as that may affect your ability to exercise. Ask for a PT evaluation and always use cooling equipment. So how does sleep affect MS? Well, fatigue is the most common complaint, right? So MS may not be the sole cause of your fatigue. Sleep disorders like apnea and restless leg syndrome are common in people with MS, and medication, mood, and other medical conditions can also affect your sleep habits. Be sure to discuss any sleep difficulty with your medical provider, because if you're not sleeping well, folks, guess what? You're creating an inflammatory milieu in your body, you're creating insulin resistance, and we really need to get sleeping. Smoking. I don't really want to see a show of hands of how many people in the room that smoke. I hope it's low, because smoking is associated with an increased risk of MS and with worse MS if you have it. And that risk is dose dependent. So the more you smoke, the worse your MS is. Smoking is a brain toxin. So it creates other problems in your brain, not just with your MS, but also with changes in your blood vessels, because of the increased risk for heart attack and stroke that also comes with smoking. Many states have free quit smoking programs, and the state of Florida is one of them. They offer excellent resources in person, on the phone, and on the computer to help you with quit smoking, including free patches and other forms of nicotine to help you quit. There are also medications available to help with smoking cessation, and you can talk to your healthcare provider about these. I'm sure that someone else today is going to talk about vitamin D. Low vitamin D levels are associated with an increased risk of MS and also with more frequent relapses and disability. Many people with and without MS are vitamin D deficient. I think it's part of many things in our society today, including the fact that we like to sit in front of these little machines and not play outside. So play outside, try to get some sunshine. Supplementation depends on your baseline level of vitamin D. Ask your healthcare provider to check a vitamin D 25,0H and advise you about how to get your level at 50 or above if you have a healthy liver and kidneys. Be sure to talk to your healthcare provider before you just start taking a vitamin D supplement. Hydration, double-edged sword. People restrict water to avoid accidents. This creates constipation. This creates dehydration. This increases your risk of spasticity, UTI, fatigue, and cognitive dysfunction. Your goal is 64 ounces of water per day. Put some fruit in it. Don't sweeten it. Start to like it and gradually work your way up on your daily dose of water. Let's talk about general health, MS and lifespan. People with MS have, in general, about 7 years less life than others due to complications of MS and other medical conditions that are preventable. So what do you need to do? Well, we talked a little bit about health and wellness. Preserve your general health. See your healthcare provider, your primary care doctor. See your primary care doctor yearly for a general physical, and more frequently if you have other medical conditions. Maintain your other medical conditions. People with vascular problems have worse MS. So if you have diabetes, high blood pressure, high cholesterol, coronary artery disease, or a history of stroke, please take your medications as prescribed and make sure you're getting checkups. Wellness behaviors are excellent ways to preserve your health. Wellness behaviors include taking care of your mind, body, and spirit, eating a healthy diet of whole non-processed foods with mostly vegetables in that diet, finding an exercise program that you enjoy, and participating in a spiritual practice. I want to talk a little bit about stress as we end the program here, because I don't know a single person that would not say that they don't have stress in their life. Stress increases bad hormones in your body. It increases inflammatory chemicals, and it impairs the immune response. Studies regarding significant stressors as causes of an MS event are conflicting. However, significant negative stressors in MS have been associated with increased MRI activity in one study. Stress is likely to be associated with a relapse if it's significant enough. And here's a nice little curve that I like to show people, because you can see that it's very easy to go from doing what you love, becoming motivated and focused and at your peak performance, and then just doing a little too much of it and becoming fatigued, exhausted, sick, and developing disease. So we need to find a good way to stay in that green side over on the left-hand side of the graph. Stress management basically wraps up wellness in a neat little package, because if your stress level is lower, it's much easier to take care of yourself, and it's much easier to participate in healthy behaviors. So how do you do that? Mental health suggestions include journaling, counseling, meditation. A couple of apps that I like are Insight Timer and Headspace. Spirituality, finding a regular spiritual practice, whether for you that is participating in a church community or in a prayer community or in a yoga community. Finding a regular spiritual practice helps to decrease stress. And that community word is really important. Finding friends, your family, and exercise groups, support groups, blogs like Stu's blog that provides you with reputable information about multiple sclerosis are all important in managing stress. So with that, I think I have a few minutes to spare, and I'll leave you with a little bit of aloha for you from my heart with this awesome rainbow and my favorite place in the whole wide world. And I thank you guys for allowing me to be with you virtually. I thank you, Stu and Bill, for making this happen. They worked so hard to get me on this screen. And it's just a blessing that we have the ability to be together like this. I think I'll be back for questions later on today. And I hope you guys enjoy your break and Dr. Boster's talk. Thanks.
Thank you, Megan. Isn't technology great? Technology, yes, it's going to help us out, and we'll be able to do things in the future as well. Who knows? Maybe one day we'll do a symposium with neurologists from all over the country, just on these giant jumbo screens. That would be pretty good. So, yes, Megan will be back during our Q&A, but right now we want to introduce our next speaker. Our next speaker is a guy that I met 5 years ago when we did a program in Cincinnati, and it was a funny thing. Before I get into reading his introduction, but we did this program out in LA, and we were in Cincinnati, and we were video recording, and I had only heard about him and that he's a really great speaker, and he gets up on the stage, and first off, he doesn't just get up on the stage. He runs up on the stage, and it's like he's got to say good morning or good evening to everybody, and just the audience wasn't loud enough for him. So he had to get down, run to the back of the room, come running all the way back up again, show all of his energy, jump up on the stage, scream out again, good evening, and he got them all to respond to him. But I didn't know that this guy liked to run around the room doing his programs, all right? And so I'm used to just the people being up here on the stage or behind the podium or whatnot, and the program begins, and what does this guy do? He takes the microphone and he starts running around the room to go around the back of all the patients and their caregivers, all right? And the cameras, not knowing that they're not supposed to follow him, chase him around the room, showing everybody's faces, and I'm screaming out, no. All right, so that guy has been great, and let me introduce him. Aaron Boster, MD, is a board-certified clinical neuroimmunologist specializing in multiple sclerosis. He currently serves as the Systems Medical Chief of Neuroimmunology and the Director of the MS Center at Ohio Health in Columbus, Ohio. As a neuroimmunologist, Dr. Boster provides diagnosis and treatment of all types of multiple sclerosis, as well as a wide range of neuroimmunological conditions. Dr. Boster knew he wanted to become an MS specialist since he was 12 years old, growing up with his uncle, diagnosed with the disease. This personal connection and experience inspired him to treat MS patients and their families differently. His relentless focus on not just patients, but also their families means they receive individualized and longitudinal care. He's got to use these big words on me. When he is not treating the patients, Dr. Boster enjoys spending time with his wife and 2 children, weightlifting, playing chess. He's also a self-proclaimed foodie. And let's welcome Dr. Aaron Boster as he runs up here and jumps up on the stage, because that's what he's going to do, right? Welcome. Thank you, man.
Howdy! I'll use the mic in a second.
Is camera 5 good?
Hello, everyone. I am super excited to be here for a couple reasons. For example, you guys have something that we don't have back in Ohio right now. Sun. Thank you very much for having me. I want to just begin by thanking MS Views and News. Not for having me here today, I am grateful for that, but for the service that they provide to our MS community, our global MS community. I can't find a parallel organization that provides this level of information disseminated to this amount of people anywhere in the universe. So can we give a round of applause to MS Views and News? If you are a plant from the American FDA, this is my rap sheet, so I'm in compliance. What is MS? What is multiple sclerosis? In order to understand multiple sclerosis, we must first start by taking a step backwards and thinking about the immune system. The immune system are a bunch of little white blood cells made inside the bone marrow of our bones. And when they leave the bone marrow, they go to school up in the thymus, which I like to call T-cell university. Now, T-cell university is a very unusual college. First of all, it's completely free. We don't have those in Ohio. Also, there's only one class at T-Cell University. The only class available is, can you differentiate self versus non-self? If I show you a cell, do you know if it belongs to you or a virus and bacteria? That's the only class. When you graduate from T-Cell University, there's only one occupation available, and that's soldier. And so all the graduates are given weapons, and they're sent out into the human body to tool around. And they check all the cells out. And when they see one of themselves, they say, hey, man, it's nice to see me. How am I doing today? And they give themselves a high five. Then when they see a virus, a bacteria, a fungus, a foreign invader, they stop what they're doing. They get out their iPhone 7, or if you're my wife, an iPhone 7 Plus, which is the size of a textbook, and they take a picture of the virus, the foreign invader, and they keep that picture, that memory, for the lifetime of the human being. Then they call all their friends over and they stomp the foreign invader to death. The next time that foreign invader enters the body, the immune system is ready and waiting because it kept that Polaroid memory of the virus. And so when people tell you that you can't get chickenpox twice, they lied. You can have chickenpox 100 times. The second time you have chickenpox, your immune system is so excited because it's been waiting since you were 8 years old to do something, and it jumps all over the chickenpox, and you don't manifest symptoms. But hold on, let's go back to T-Cell University. What happens if you fail the class at T-Cell University? Remember how I told you it's a very unusual school? They take you out back and shoot you. So that's kind of the downside. You know, it's free to get in, but if you do poorly, it doesn't work out very well. Only cells that can differentiate self versus non-self are allowed to live. Theoretically speaking, you should have no cells that can't do that. Unfortunately, there are times where our immune systems make an error in judgment. There's a mistake made, and one of the cells at T-Cell University fails the class, and they don't kill him, they graduate him. So he gets some weapons, and he's a soldier just like all of his buddies, and he goes out with all of his friends, and he does what he thought he was taught to do. And he tools around the human body. He sees a self cell and mistakes it for a foreign invader. He does what he was taught in school. He takes a picture of it, he calls his friends over, he stomps on it. And every single time one of those cells sees that, it thinks it's an invader and attacks it. The problem is that is actually part of you. That's called autoimmunity, friendly fire. I asked my stepbrother, who's a United States Marine, and he confirmed you're not supposed to shoot your buddy on guard duty. And that's really what's happening in the setting of autoimmunity. Now, if the autoimmune reaction occurs in the pancreas, what do we call that? Diabetes, that's exactly right. And if it occurs in the joint, what do we call that? Rheumatoid arthritis. You guys are awesome. I'm just going to take a break and you can keep going. Now, what happens if the immune attack occurs in the holiest of holy, the supercomputer that runs the entire body, the brain, or the spinal cord, the superhighway that takes all that information from the brain down to the toes and back up? What do we call that disease? Yeah, that's multiple sclerosis. Now, we can think of MS several different ways. For a moment, I want us to think about it as potholes. Now, in Ohio, we have 2 seasons. We have winter and construction. And during construction, we fix all the potholes that occurred during the winter. Now, do you have potholes in Florida? Oh, you do? Okay. I thought maybe it was like an Ohio thing. So, how many of you, show of hands, have done the following? You're driving on the freeway, you see a pothole, stop your car, get out of your car, take a picture of the pothole, call the city and say, hey, I want to report a pothole here, and then you wait for the pothole to be filled. Show of hands. You know, nobody ever does that in Ohio either. What do we do when we see a pothole? We just drive around it, right? We're eating a sandwich, talking on the cell phone, driving 80 miles an hour, and we see a pothole, and we just go, we don't even think about it. MS makes potholes in your brain. MS causes focal areas of damage like a pothole. And your brain will ignore it if it can. It'll go around it, just like your car, if it's able to. So there are times when there's no workaround. If there's a pothole and your car can't get around it, you might be stuck. There's parts of the brain and spinal cord like that, like the optic nerve. You don't have two of them on the left side, just one. And if you have an MS lesion there, you're not going to see very well. But there's many, many other parts of the brain and spinal cord where it's not so straightforward. And that leads me to comment on the invisible nature of multiple sclerosis. So much of the pathology of MS is invisible to the casual observer. This is a major frustration for everyone involved in MS because you can't see it. And I want to highlight some of the invisible nature of this disease process by sharing with you a really powerful survey that was done. They asked 1,000 people with MS and a bunch of care partners a bunch of questions. And what they learned about the underbelly, the invisibleness of MS, is daunting. Half of people with MS reported that depression and anxiety limited their ability to do things. 2/3 of people said that those around them didn't know they had MS because, honey, you look so good. You ever heard that before? But honey, you look so good. You don't look like you're sick. Well, you don't look like you're dumb. Sorry, I shouldn't have said that. So half of people that responded, half of people said they couldn't do their housework because of fatigue. Now think with me, please. Many people judge the value that they bring to their household by the cleanliness of their home. Anybody feel that way? Yeah. Imagine that your spouse goes off to work and you're at home and your task is to clean the house. And you are so profoundly fatigued you can't. Imagine how that feels. And your spouse comes home and says, honey, what have you done all day? I think that is so terribly telling about the invisible nature of this condition. The last one is that 1/3 of respondents determined whether or not they went out of the house on any given day based on their bladder. Wow. Wow. I would now like to share with you a way of understanding MS that I find awesome. It's called the leaky pool model of multiple sclerosis. Anybody heard of the leaky pool model of MS? Show of hands. Well, I am super excited that I get to talk to you about it today. I did not invent this. I take no credit for its construction or conception. A good friend of mine, a really awesome neurologist named Stephen Krieger, who's at Mount Sinai in New York, he made this. But I am an alkalite of it. I adore it, and I'm really excited to share it with you. This is a model of multiple sclerosis that I share with almost all of my patients when I'm in clinic with them, because I think it helps us understand the disease. So look at the board, if you will, and what I'm showing you, that graphic, is intended to be a swimming pool in cross-section. And let's see if this pointer works. So here you have the water level of the swimming pool. This is the shallow end, and this is the deep end, all right? And that's the floor of the swimming pool. Now, this surface, the surface of the water, is called the clinical threshold. What that means is things above the surface of the water, the human being is aware of. I can't see out of my left eye. My down theres don't work. My leg's numb. My hand's weak. Symptoms. Everything below the water level, inside the pool, the human being is completely unaware of. They don't know that there's something wrong. But you can see it on the MRI. Now, the amount of water in the pool represents the functional reserve. What is functional reserve? The functional reserve is your nervous system's ability to withstand an insult. Not an insult like you're ugly. I mean like I didn't sleep last night, or I have a urinary tract infection. Something like that taxes the body. And the nervous system has different amounts of functional reserve in different parts of the nervous system. So, for example, the spinal cord has very little functional reserve. It can't withstand an insult very well. The top of the brain, which is shown in green on the right, there's a lot of room, a lot of functional reserve. Now, the way that we represent the nervous system is on the surface of the floor here. And so I just alluded to the fact that the deep end, that floor is the top of the brain, the lobes, the hemispheres. The middle portion there represents the base of the brain stem. And on the far left, in that pink salmon color, we see the spinal cord and optic nerves in this model of MS. Now, the water level slowly lowers a little bit each year. It's leaking. But it can change from day to day based on many, many factors. And I'm going to come back to that point in a second. So how do you represent activity? You guys understand that activity means a clinical attack, a flare, an exacerbation, a relapse. It's when something bad happens to you and you can't hide it from your spouse, or a new MRI spot. In this model, we show activity by a stalagmite sticking up from the surface of the swimming pool. Now, I would not like to swim in Stephen's pool. What we see here, those white things pushing up from the base, these are areas of activity in various parts of the nervous system. And if, like in number 1, the activity crests the surface, it goes above the level of the water, that clinical threshold, that's an attack. You're aware of it. But if it's below the level of the water, like number 2, you're not aware of it, but you can see it on the MRI as a new spot. Now, progression is eloquently explained using this model. I'm showing you here the water level, and you see that some of those spikes are under the water. Over time, as the disease progresses, what happens is the water level drops. Now, I want to show you my amazing PowerPoint skills. This was as close to a video as I could pull off. So the water level drops. Yeah, sorry. So, and what you see when the water level drops is that you uncover areas of old damage. Areas that weren't clinically affecting you, as the water level drops, as the functional reserve drops, become affected. And that is the underpinnings of progression. Let me explain it another quick way. I don't own a firearm, but let's pretend that I had a shotgun and I blew a couple holes in that wall. Now, some bad things are going to happen to me, but let's pretend that the hotel doesn't fix it. All right, now there's a couple shotgun blasts in that wall. Well, then a couple years from now, Florida's big earthquake occurs, God forbid. Which wall in this room falls first? The one with the holes in it, right? The one with the structural damage. And in the same fashion, the areas of structural damage from those lesions on the MRI, the areas that caused an attack, wear out as the functional reserve diminishes. And that's the underpinnings of progression. The model also explains heat sensitivity. August in Florida is rough without MS. It's really hot. And many of my patients in the summer times, they struggle because they get overheated and their legs give out. What's happening can be explained using this model. When they go outside, the functional reserve diminishes, the pool drains some of its water, and those old areas of damage come back out. But it's temporary. Because when you go back inside and guzzle water and you're in the air conditioning, the level rises. And so it's a very dynamic process. Thank you for letting me explain to you Stephen's leaky pool. And I hope that it helps us conceptually understand a little bit about how this disease behaves, specifically as it relates to new attacks and inflammation, activity, and progression of disease. I now want to switch topics. And I want to discuss with you disease-modifying therapies, MS drugs that slow the disease down. And I want to start by talking about the expectations of a drug. If you are on oral birth control, you have an expectation, don't you, to not get knocked up. That's why you're taking oral birth control. And you have to understand the expectations of the MS medicines. I think that we do. I also am excited to share with you that these definitions, these concepts, these expectations have evolved over the last 10 to 20 years. And so, all right, so starting off, I want to talk about what I call traditional goals of MS therapies. Blue is clinical. Red is MRI. And we used to say things like, if you take this shot, I can decrease the number of attacks by 1/3. So if you are predestined to have 3 attacks next year, you're only going to have 2. And I can make you get worse in progression of disability to a lesser extent. I can slow progression by 30%. And I can make you have less spots on your MRI. Now, essentially, what I felt like I was saying with the traditional goals was, hey, man, I can make you get worse slower. There is no pride in my voice as I look at someone, a father, a mother, a sister of someone, and say, I can make you get worse slower. That is not my goal in treating multiple sclerosis. And I don't want it to be your goal. I don't want that to be your expectation. Those are no longer the expectations of these drugs. We now have moved past that. And we now can ask different questions. Instead of saying, can we have 1/3 less attacks? How about no attacks? Oh, I'm sorry. I expected an amen. Amen. How about no disability progression? Amen. How about no new spots on your MRI? Amen. The expectation, the goal of no evidence of disease activity is today. Now, I'm not standing up here and saying for a limited time only, for $9.99, if you sign up now, I can guarantee you netta. I am not saying that. I'm saying that's the goal of the therapy. That's what we should ask for, and that's what we should assess the success of the therapy against. Does that make sense? Yes. Now, it gets even better because we have started to move beyond that. Evolving goals. There are now powerful MS therapeutics that can bring to the table confirmed disability improvement. Oh my goodness gracious, to stand up on stage and talk to you about confirmed disability improvement. I never ever thought that I would get to do that. And I do today, right now, because we have MS medicines that demonstrate that people get better. Their neurological examination can improve for periods of time. I also think in the MRI world that we're now starting to ask questions about the speed of shrinkage of the brain. And so I want to spend a few minutes talking about these new modern outcome measures. No attacks, no new MRI spots, and no change on neuroexam. So much win. I love Picard, by the way. netta. I like netta a lot. But I'm afraid that most MS doctors don't understand it properly. And they say things like, netta doesn't occur for very long or for very many people, or it doesn't work very well, and they think about it as a yes-no. You either have it or you don't have it. That's not the right way to think about netta. I want us to conceptually think about this like the sign in my father's factory, days since last accident. And if you had a day with no accident, they flip a little sign over, and now there's 1 day, 2 days, 10 days, 100 days, no accident, hoorah! And then there's an accident. My father didn't close the factory. He did a root cause analysis, he figured out what's wrong, he made a change, and then he started it over at 0. Did you guys know that if you can achieve netta for 1 year, you've got a 73% chance that your neurological examination stays exactly the same for 7 years? Did you know that if you can hold netta for 2 years, data suggests that we can have stability 7 years later, almost at 80–85%? This is yeah, that's right. This is a powerful, powerful tool, prognostically. Who knows what this is? This is the EDSS, the Expanded Disability Status Scale. This is the scale that the FDA makes us use to assess disability in a human with MS. According to the scale, 0 is, I can't find nothing wrong with you on exam. 6 is, I need a cane to walk. And 9 is, I can't roll over in bed. Now, this is a graphic that I stole, like all of my images, from the interwebs. And I picked this one specifically because this has a directionality to it, doesn't it? The way this is drawn makes an assumption that the only option is to go down the down escalator. Because up until very recently, that's all we could do. No longer. We now go up the down escalator. Yeah. Woohoo! Yes, we do. We have seen therapies now where small percentages of patients improve their neurological status and they go from a 5 to a 4. Now, they may not stay that way the rest of their lives. They may only do that for 6 months, but golly gee, I'll take it. Confirmed disability improvement is something that we should be talking to our MS clinicians about. And this is something that we should be asking for. And we now have some therapies that are starting to demonstrate they can do this. NEP. Anybody here ever heard of NEP? NEP. I didn't make up the term NEP, but I kind of like saying it. Say it with me on the count of 3. 1, 2, 3. NEP. That was kind of fun. So NEP is a new outcome measure in primary progressive multiple sclerosis. In primary progressive multiple sclerosis, NEP means no evidence of progression. For a 3-month period, we can see people who have PPMS, their walking doesn't slow down, their neurologic exam doesn't change, and their PEG speed doesn't worsen. They have no evidence of progression for a period of 3 months. And we now have a therapy that can double the likelihood of achieving that in people. Really very, very cool. A new expectation as we treat primary progressive multiple sclerosis. The last expectation I want to talk about is brain volume. And Bill's going to hit this button for me. Now, a friend of mine, Elizabeth Fisher, was nice enough to lend this video to me. And this is a video of a young gentleman that refused to start a disease-modifying therapy. And this is his brain volume over 7 years. Now, you don't need to go to doctor school to recognize that that's bad for you. Brain shrinkage is something that our brains are supposed to do. Anybody here under the age of 18? Well, I have something horrible to share with everyone else in the room. All of our brains are shrinking. After the age of 18, it's planned. Just like your skin gets thinner, your brain shrinks over time. But untreated MS, it can shrink upwards of 10 times faster than it's supposed to. That's a really big deal. It's the leading correlate to disability progression. And we now have some MS medicines that can slow this down. We have some MS medicines, it looks like it can normalize the brain volumes. And again, this is a new expectation of our medicines that we should demand from our therapies. Really cool stuff. Slowing down brain atrophy. Whoops. Oh, I ruined it. You saw my fun slides. So I'm now going to shift gears and talk to you about how every single MS medicine works, and I'm going to do it only using pictures. But I first want to explain in general picture how this MS medicine thing works. If you will, imagine that the line here is the blood-brain barrier. Now, because it's hard to see a line, I need a volunteer from the audience, and you got to be quick. So yeah, come up here if you would. This is the blood-brain barrier. Let's give the blood-brain barrier a round of applause. Now, please lay down on the floor. Yeah, right. No, I'm serious. Right there. Yeah, you're the blood-brain barrier. All right. So on one side of the blood-brain barrier is the blood. And over here we have the naughty autoreactive cells. They have to cross over the blood-brain barrier into the brain. This over here is the brain where the cell attacks the brain. So again, the naughty autoreactive cells are over here in the bloodstream. And they cross the blood-brain barrier where they gain access to the brain and they beat it up through inflammation. Every MS therapeutic that we have does something to prevent that from happening. It either retrains the cell over here, or it kills the cell over here, or it blocks the cell from crossing the blood-brain barrier, or it retrains or tries to kill the cell over here. Every therapy does that in some fashion. Now, Let's give our blood-brain barrier a huge round of applause. Thank you. Now, with that preamble, let's start talking about how these drugs work. In the upper right-hand corner, I've given you a little graphic to remind you that interferon products are injections. They're self-injections. And the way that the interferons work is they tighten the blood-brain barrier. So if the normal blood-brain barrier that we just saw is like the straw house in the Three Little Pigs, if you squirt interferon on it, it becomes the stick house. It's a better house. And it makes it harder for those cells to cross over. And because they can't gain access to the brain, less bad stuff happens. Interferons. The next slide looks at glutarimer acetate. Glutarimer acetate doesn't do anything to the barrier. Glutarimer acetate is synthetic myelin. It looks like myelin. And every day or 3 times a week, you show your immune system its target. You say, hey, immune system, see that? And then 3 days later, when you re-inject, you show it to him again. Say, hey, remember that? Well, look at it again. And then a little bit later, you say, yeah, now look at it again. And the immune system quite literally becomes bored. It becomes bored. So instead of being a pro-inflammatory like these guys got drunk, then they went to the bar. They wanted to fight. But after showing again and again the immune system its target, they're no longer all that interested, and they just kind of want to order pizza and hang out at home and watch reruns. And that's what glutarimer acetate does to slow down MS. Aubagio is the trade name for teriflunomide, and this is a pill, and I'll give you a little pill symbol up there to remind you of that. The way Aubagio works is it prevents your body from being able to rapidly produce new clones, and it makes me think of stormtroopers. So if you slow down the production of stormtroopers, you don't have as many, and they can't go out and attack you as frequently. And so Aubagio puts a stop on the ability to rapidly make a bunch of stormtroopers. And that's how it slows down MS, because there are less cells over here that can cross the blood-brain barrier and attack the human's brain. Fingolimod, codenamed Gilenya, is a pill that you take. And the way it works is really weird. It tricks your cells, about 80% of your white blood cells, into being trapped in your lymph nodes. I don't know if you know this, but all the white blood cells in your body, they do this thing. They go around the bloodstream, then they go through the lymphatics, then they leave the lymphatics. And what this drug does, when they enter the lymphatics, it traps them. It doesn't kill them, it sequesters them. And it reminds me of the Eagles Hotel California. You can come in anytime you want, but you can't leave unless I forget to take my Gilenya. Dimethyl fumarate, or Tecfidera, is a pill taken twice a day. And it does something different as well. It tricks the white blood cells into thinking they're under oxidative stress, and they respond with an antioxidant cascade of lovely, which slows down multiple sclerosis. This is a very unique mechanism of action, Tecfidera. Diclizumab. Now, in the upper corner, I included that little Y symbol. That's actually a cartoon of an antibody, because diclizumab is a monoclonal antibody. Monoclonal antibodies are like keys. If you find your car key in your pocket, how many car doors does that key open? Hopefully just yours, right? It's specific for your car. Monoclonal antibodies are smart bombs that are specific to something in the body. And it's kind of like a bomb that only kills the chickens. You drop a bomb and the farm's fine, except now there's no more chickens. It was very, very specific. That's called a chicken bomb. I just made it up. But what we see here is a monoclonal antibody called diclizumab, which is given by an injection once a month. And what it does is it sabotages the machinery of MS. I found this factory picture, and I think about, machine A to machine B to machine C. Well, what this drug does is it breaks machine B. So the cascade stops by interfering with the machinery. It's like sabotage. Diclizumab. Natalizumab, codenamed Tysabri, also does something to the blood-brain barrier. And if you think of the nascent blood-brain barrier as the straw house in the Three Little Pigs, I told you if you squirt interferon, it becomes the stick house. What happens if you put Tysabri on it? It becomes the brick house. And now you have to sing with me. She's a brick house. Woo, mighty, mighty. Now, so what we're dealing with here is the Great Wall of China. We create a barrier so severe that no cells can cross. They stay in the periphery and they can't enter into the central compartment with Tysabri. Alemtuzumab, codenamed Lemtrada. Now, truth be told, I couldn't find a fun picture, so I just used this one. Lemtrada is also a monoclonal antibody, as evidenced up there in the corner. But it's not an injection, it's an infusion like Tysabri. This drug is given for 5 days, you wait a year for 3 days, and then you might not get it again unless you have new disease activity. This drug works differently than every other drug I've talked about because this drug doesn't try to prevent the cell from entering, it tries to retrain the cells forever. And what I mean by that is it kills the adult B and T cells and it forces the baby cells to grow back nicer. Quite literally, the cells that return after you kill all the adults behave differently, and it's really, in some ways, a reboot or a reprogramming of the immune system. Alemtuzumab. Ocrevus, the newest drug to join the MS armamentarium, works on B cells. It's a monoclonal antibody. It's infused twice a year, and the way that it works is fascinating. Now, when I think of this drug, I think about high school boys that bump into each other in the hallway, and they decide the best course of action is to duke it out behind B building at 3:30. Gentlemen, you remember that? And so when they show up to fight at 3:30, they show up with 6 of their best friends. If a young man shows up at 3:30 to duke it out without his friends, guess what he's not doing? He's not fighting. He's going home. Now, in this analogy, the fighter is the T cell that wants to attack your brain, but the B cells are the friends. With this drug, we murder all your friends. And so you have no buddies to rile you up to go in there and fight, and the T cells, I don't really want to do that. That's how ocrelizumab works. I'm going to wrap up with a call to action. Look at this graph for a second. On the x-axis along the bottom is time, so as you go from left to right, I lose hair. And on the y-axis, going up and down, is disability. Going up, you get worse. And what you see in black is an untreated MS patient over time. Then what you see is if you start a disease-modifying therapy, you can adjust it, so over time, the human accrues less disability. But let's push the envelope. Let's use a highly effective medicine as early as possible, and look what happens to the curve. I really believe in my heart that we need to use high-efficacy disease-modifying therapies as early as humanly possible to give people with MS the best chance of living awesome lives without disability. If you have a birth control pill and you are taking it the way you're supposed to, and you get pregnant, it didn't work. And if you're taking a disease-modifying therapy and you have new spots on your MRI, it didn't work. So why on God's earth would you remain on that therapy? Or why would you not at least discuss switching to something else? I want you to ask yourself in the quiet of your heart, have you participated in therapeutic inertia? Therapeutic inertia is a situation where we identify a need for change and we don't. And I implore you to demand of your clinician, hey, buddy, I'm doing the thing that you told me to do and I had an attack and it's the second one I've had in 2 years. I don't want to stay on this therapy any longer. Because undertreated MS is a lot like untreated MS, in my opinion. Now, I think it's relevant to talk about when you got to dump your drug. We do not marry our MS therapies. We date them. And as long as he's a gentleman and a good dancer and a nice kisser and he goes to church and he's good with the family, well, we'll keep seeing him. But if he starts to misbehave, comes home drunk, is impolite, maybe steps out and spends some time with someone else, we're not going to put up with that. And we're going to have to tell that drug that you're going through some personal things, and it's not him, it's you, and you need some space, and that you'll call him soon, and then you got to delete him out of Facebook and take him out of your phone and never ever call him ever again. So when do you need to dump your drug? Whoops. If you're on an MS medicine and you have an attack, if you're on an MS medicine and you fail the litmus test of life, you have to remove activities. If you're on an MS medicine and you have new spots on your MRI or you worsen in your disease, if you're on an MS medicine and you are uncomfortable with the safety profile or the side effects, that is rationale to have a discussion with your provider about changing therapies. Final thoughts. I want the people in this room to be 4 for 4. 4 for 4 in your fight against MS. Number 1, don't smoke. Smoking cigarettes speeds up MS by about 50%. Stopping smoking speeds it back down. I didn't do that. The second thing is to be physically active. We just heard a beautiful lecture just before I got on stage about the benefits of exercise. The third thing is to supplement your vitamin D, because levels lower than 50 drive the disease faster, but higher levels seem to slow it down. And lastly, take a disease-modifying therapy and make sure it's working. In the final moments on stage, I want to leave you with this thought. I want you to conceptually think of multiple sclerosis as an unwanted passenger in your car. I wish to God I could cure the disease. I don't know how yet. I can't get the disease out of your car. So you have to make an important life decision. Who drives your car? Does MS drive your car? Because if you allow MS to drive your car, you won't like where it takes you. Here's what I want you to do. I want you to drive with MS in your car to a big box store. I'm a Lowe's guy myself. If you like Home Depot, I don't stand in judgment of that. But I want you to go to your big box store and I want you to pick up 3 items: a lead pipe, a bunch of rope, and some duct tape. And then you go back to your car, open the door, take the lead pipe, beat MS silly, tie his hands behind his back, tie up his legs, gag his mouth with the duct tape, drag him in your trunk, throw him in your trunk, lock the trunk. I want you to sit in your driver's seat, and I want you to turn the radio way up. My preference, Paul's Boutique, circa 1984, Beastie Boys. Play it loud and proud, and I want you to drive your car. Thank you, everyone. Have a great day.
Thank you, thank you, thank you. Always a pleasure. All right, briefly for 3 minutes, Jeff Siegel is here. Jeff's going to just loosen you all up, and then the doctors are going to come back up here, and Megan will be back up on the big screen, and we're going to start our Q&A. So you got it, Jeff, for 3 minutes.
I hate to disturb your lunch, but activity is what drives us. So I'm going to ask you guys to do a couple things. It's going to take a couple seconds, and it'll help you out, help you concentrate. If you can stand up, I'd appreciate it if you would stand up. Take a break from eating for just a second. And if you can raise your hands up in the air, raise your hands up in the air. If you give the person next to you a high five, give them a high five. I want you to repeat after me. Look to your right, and I want you to say this. Say, this guy was great. 1, 2, 3. Oh, thank you guys. Now I'm going to go home and I'm going to tell everybody that everybody stood up. I want you guys to cheer a little bit. Okay. All right, now look to your left and say the same thing. This guy was great. Okay, I'm going to go home tonight. I'm going to tell everybody that I heard everybody say it twice. This guy was great. So I did a good job. Move around a little bit, then you can get back to your eat. All right? So far, program's phenomenal, right? Cheer. Let's go. I want a round of applause for everybody. That's movement. The more you move, the more you can move, and the more you want to move. And then there's the contrary. But don't go that way. Are you guys ready for a great rest of your program? All right, now I want everybody to give a low five to the person next to you so no one sees. Low five. Continual movement. Now I want you to chew your food all the way. That's moving, right? So you're burning calories as you're eating your food. That works all the time. So you like your food? I haven't got a chance to eat it yet, so I want some feedback. Should I go back to my table and eat my food? Okay, I will do that. Are you guys ready for some Q&A? All right, we're going to start that in about 1 minute and 20 seconds. So I want you guys to do jumping jacks, stand up, push the person next to you down, help them up, and then sit down and eat. No? Okay. You guys can tell when I'm kidding by now. How many people in here have seen me speak before? Okay, that's about 39%. Wait, 40%. All right, I will be coming back up to get you guys to move around after you've enjoyed your food, because you are going to be a little bit more tired than you are right now, and you'll be able to concentrate just a little bit better on what your questions are going to be, the responses. So you guys have questions ready for everybody? I mean, they didn't explain everything so well that you don't have any questions? Of course you got questions. All right, well, they're going to have the answers, and thank you guys very much. This is not the question time until he tells you guys.
Maria.
All right, Stuart, you are up.
Thank you much. All right, so everybody, listen, we're going to have 2 people in the room going around the room taking questions, all right? And we need you to please raise your hand so that way the people that are going around the room can get a microphone to you. If you have a question, please raise your hand right now, all right? Great. Now we know where we're going to start. So 1 minute, I'm not ready yet. If anybody's got a question for Megan, say your question, but then I'm going to have to repeat it because I don't know if Megan can hear what's going on out in the audience. You okay with that, Megan? Shake your head. Megan? Can you hear me?
I can hear you, but it's muffled too. If there's a question, I'm going to...
How about now? Can you hear me now?
Yeah, that's better.
Okay, great. See, that's what happens when you don't have the mic here. Okay, great. So people from the audience, if they have a question for Megan, say your question. I'll repeat it for her, and then she'll be able to answer. Otherwise, you just speak with these 2 doctors here, and they'll be able to answer your questions. So first up, we're going to switch back and forth, left side and right side of the room. Go for it.
Yes, Stu, I need to get some relief for MS hug.
So MS hug, sorry, I'm short, and nobody puts baby behind a podium. MS hug is a situation oftentimes where there's been damage to the spinal cord, and it causes spasms of the muscles between the ribs. It's the kind of hug you really don't want. And it oftentimes is described as feeling like you have a lasso around your body and someone's tied it to the back of their truck and they're driving away and you're getting squeezed. Sometimes people end up going to the emergency department because they think they're having a heart attack or something. It's a really painful thing. Now, there's some treatments that can really help. And it's not narcotics. You don't want to use narcotics for this kind of pain. We want to use either a medicine like baclofen that helps relax spasming muscles, or one of the medicines invented for seizures that stabilize cell membranes, like Tegretol. And so there are therapies that can be very, very helpful in trying to address the discomfort of the MS hug.
All right, next one's from the right side of the room, and then I have a live stream one to put in too.
Hi, this is a question for Dr. Boster. You said that all these drugs have different mechanisms of action. Why can't you just try 6, maybe 7 different MS drugs and take them all together to cover all your bases? And why wouldn't that be a good idea?
That's an awesome question. And I'm not sure where you are, so I apologize if I'm not looking at you. Hi. So that's an awesome question. First of all the MS drugs I described today are anti-inflammatory agents, right? And we need 3 kinds of MS therapies. We only have 1 right now, anti-inflammation. We need remyelination, and we need neuroprotection. We don't have those yet. One of the reasons you can't stack all the drugs together, to do that in a clinical trial would cost billions with a B dollars. It's too expensive to even test. And so it's very, very challenging to do clinical trials to try to answer those questions of combination. The other thing is, all of the drugs have side effects. And sometimes if you stack them on top of each other, the side effects multiply. I think that there is room for some investigations in combining drugs, but it's a very tricky business for those reasons.
That's an excellent question as well. There was one trial combining a interferon and glutathione, and it really didn't work that well. For some reason, combination therapy of those two drugs didn't work as good. That's number one. Number two is that some of these drugs have legacy effects in terms of how they work in the immune systems. So it can deplete certain immune cells that are really important to fight off infections. And if you stack another immune cell depleting agent on top of that, it may increase potential unwarranted side effects.
All right, so there is a question here from live stream. And before that, though, there are people that did sign in after we began the program. So I just want to let anybody know that is on live stream. You can text your question to 954-684-1683. It's 954-684-1683. The question that I have is from Megan. Megan, you there? Megan.
I'm here.
Great, good. How are you? This person wants to know.
Great.
This person has a symptom management question. She says she's very fatigued all the time, and her family poo-poos it all the time. And she wants to know what she could say to her family to get them to better understand why her body doesn't want to move in the afternoons and why she's getting this like brain fog all the time every afternoon.
Okay, so just to make sure I'm understanding it right, so she has brain fog and she's getting fatigued and her family doesn't understand.
Exactly.
Okay, so how do you make your family understand? So one of the challenges with MS, depending on what you look like when you're living with MS, is that old adage of, quote, but you look so good. And people truly don't understand. There's a great, I guess I'll call it a story that I like to refer people to. It's called the spoon theory.
Yep.
And the spoon theory was created by a woman who has lupus. And one of her girlfriends asked her to describe what it was like to live with lupus because she didn't have any outward manifestations of the illness. And the woman said, well, it's like this. Every day I start my day with a jar of spoons. And those are all the spoons that I have for that day. So if I need to do something in the evening for my kids, then I need to be sure to reserve X number of spoons for the evening and not use them up in the morning. So going out to lunch with you today, friend, has cost me 10 spoons, and I only have 3 left at the end of the day to, take care of my family and take care of myself. So that's one of the things that I like to share with people, how to get their families to understand. And you can actually find the spoon theory online written down and printed out. The other thing that you can do with your family when they don't understand is ask them to come to a doctor's appointment with you. Yep. Ask them to look at your MRI with you. Go over the things that you think through and that you do every day living with MS to make sure that, you have enough energy just to do your activities of daily living, which are things like getting up, taking a shower, walking to the bathroom, making meals, and then throwing in all the other things that we need to do living as humans these days. But I really do encourage people to have their loved ones that aren't understanding to try to get them to come to a doctor's appointment, and also to get them to come to programs like this and to other programs that are given in the community for people living with MS. That tends to be, for me, what I hear back as is the most helpful, is families seeing other people living with MS that look like me, and finally he or she gets it. So those are my suggestions. I hope at least one of them is helpful. But you can find that story. It's called, just Google the spoon theory online.
Thank you very much. Next question. Where are we? Left or right side of the room? Left side, right there. Go ahead.
My question is for Dr. Boster. It's not really a question. I just want to say that I've had therapeutic inertia for the last 7 years. I have progressive MS, and you really inspired me today. And I want to know if you're taking new patients, I'll fly to Ohio.
I knew this was going to happen. Here comes the hug. Okay, to the right side of the room, we have a question. Just way in the back first, and then we'll come forward.
All right, I'll second that. I want to hug and I want to get married. But anyway, firstly, I need to say I've been to many of these symposiums, and I want to thank you, Stu, for getting them all together and bringing this community together. Today is an exceptional one, I think. I've been so inspired by all of our speakers. But there's an irony about MS. I don't know if what percentage, but I imagine many of us, including myself, are on disability and therefore have Medicare. I'm on a Medicare Advantage plan, which is the most cost-effective way to go. And although I have an excellent MS clinician, with MS comes sometimes other autoimmune problems, which don't play nice together. And I cannot get insurance to cover the very few people who are immunoneurological people. And I want to know what to do because it's exceptionally frustrating.
So, yeah, I certainly agree with your frustration. The thing is that a lot of the pharmaceutical companies and the benefits that they can participate in are restricted for government assistance plans, which is Medicare and Medicaid. So commercial insurance, you can get patient assistance for drugs and things like that, but unfortunately, because of the regulations, the hands are tied for the most part with Medicare patients. There are programs out with funds and foundations that you may be able to apply to increase your chance of further assistance. But I feel your pain every day with a lot of my patients in the same boat.
Thank you. So the next one again is from Megan, and fortunately I was able to just text this to her as well. So I'm going to ask the question. Megan, I just sent you a text message, and the question is this. Megan, how important do you feel individual therapy is, knowing that most licensed counselors do not have an understanding of true MS struggles?
Okay, so you mean counseling, behavioral therapy?
Excuse me?
Is that what you're referring to, Stu?
I sent you the message that was sent to me.
So I do think that individual counseling can be very effective, and even though there may not be counselors that are trained in specifically issues related to MS, there are many other chronic conditions that have symptoms and problems that are pretty similar to multiple sclerosis. And there's a period of adjustment that goes along with any change in one's life that affects significantly the way that they're able to live their life. So I do think that counselors can do a very good job helping you to navigate through these changes, but you have to find a counselor with whom you have a good rapport. The MS Society has an MS Navigator program that when you call the MS Society, they can hook you up with an MS Navigator that can help you with counseling and support as well. But I do encourage people to try counseling. It's not just for people who are having a very significant problem in their life. It's helpful for just those of us living with day-to-day stressors. So looking for a person who specializes in multiple sclerosis is helpful. But please don't abandon ship if you can't find one. Just try to find a counselor with whom you have a good rapport and can talk to and bounce issues off of.
Thank you for your reply. Next question. Anything on the left? Maria, all the way up front. In the meantime, I'm going to go right to the rear, right to the right. Go.
Yep, Stu. This has been an excellent program today, and I want to thank you for bringing it to us today. My question goes to Dr. Negroski, and it has to do with electronic health records. It seems that with the system that everybody has access to the records except the patient. And I'm wondering, should a patient be able to see the doctor's notes that are put into this electronic health record?
With electronic medical records, you have to understand that each system is a little bit different. So some systems do not communicate with other systems. So that was kind of the bottom line when the stimulus package was rolled out in 2009 and the HITECH Act. The records were supposed to be kind of like if you show up in a office in Wichita, Kansas, and you move to Sarasota, Florida, those records you can just press a button and they are transferable. But that's not the case because the companies don't communicate with each other. So some companies do have systems that you could print up your own complete chart, the whole chart, the doctor's notes, the nurse's intake, everything. Some systems are less streamlined. So until the whole system kind of communicates with each other, you're kind of left out hanging, so to speak.
Thank you for your reply. Next one, anything on the left here? I can't see, that's why my hand is up high. Maria?
Hi, my question's for Dr. Boster. I'm having a lot of trouble comprehending. I've diagnosed 2 years ago. At the time, I had multiple lesions and black holes, so I had it for obviously a long time. The new symptoms I get recently out of nowhere, I don't understand how they just pop up, I guess, because when I am on Tasabri and they say I'm stable, no new lesions the last year, so I'm having a hard time understanding the new symptoms that seem to keep popping up.
So you bring up an outstanding point, that as a human being, when we experience something, we don't necessarily know why we're experiencing it, we just experience it. So if you start coughing, you might have swallowed a feather, or you could have tuberculosis. You don't know, you're just coughing. And in a similar fashion, when a person with MS has new symptoms, it's not always transparent or easily understandable as to why they have those symptoms. My recommendation is write them down and document them as carefully as you can. Bring that to your clinician and sit and have a conversation with them. Say, I need you to listen to me, and make sure you explain how those symptoms are impacting the quality of your life so that they can hear you. If you say, my hand's kind of numb, and I'm a professional piano player, that helps them understand that this is not just a little numbness of the pinky, this is interfering with your vocation. And hopefully, working with your healthcare provider, you can try to sort out, is this an attack? Is this a pseudo attack? Is this progression? Is this not related to multiple sclerosis? It can take a little bit of work, but it's worthwhile. I wish you the best of luck.
Thank you. Next one is from live stream again, and this one looks long only because it's on my little phone. Boster, how soon after initial treatment should new spots on an MRI encourage a medication change? I ask because 4 months into Gilenya, new lesions were shown, but my neurologist had me continue for 12 months before switching, as she believed that it was still talking time for my brain to calm down. I feel as though I lost those 8 months when I could have tried something sooner. Your thoughts?
That's an awesome question, thank you. And I agree with your neurologist, actually. So when I said you see a new spot on a scan, that's a time to discuss switch. I don't mean that you necessarily switch that morning. I mean that you're now sensitized
that something's not right. And you have to consider all the variables. If you had been on Gilenya for 4 years and had a new spot, that's different than if you just started it. Because these drugs don't start working right away. Gilenya is amongst one of the faster ones, and I typically expect it to start to do something somewhere between 3 and 6 months. I get an MRI after I start someone on a drug 6 months later. If I see a new spot, I do not switch them yet. What it makes me do is get another MRI 6 months later, and if that one also has new spots, now I switch drug. Because we can't be too quick to judge. If you have a splitting headache and you swallow an aspirin and count to 10 and ask yourself if it worked, and it didn't work, you say, oh, the aspirin didn't work. Well, we know that you have to give it a bit more time. And so in this instance, I agree with her decision. Would you add?
No, I agree 100%.
Thank you. That side.
Great panel. Thank you so much. I had a quick question. I had a friend that sent me a podcast about lion's mane mushroom. It's supposed to be a neuroprotectant. It promotes remyelination and neurogenesis. Now, I was just wondering, is there any current studies out on whether it's CBD oil or any kind of holistic medication to see if there's any efficacy on that?
So, to my knowledge, I'm not familiar with the mushroom thing. I did have mushrooms last night, and but
how do you feel?
So, who, me? Great. So the thing is that, as I mentioned earlier, there's different sources. There are informative things, research trials with placebo-controlled double-blind studies, and then there's anecdotal reports about certain diets and certain over-the-counter medications and certain things on the internet. So what works for one patient may not necessarily work for you, but I'm not familiar with any long-term clinical trials on that product.
If I could share some guidelines, because if you go to the health food store and tell them you have MS, they're going to say, oh, great, come with me. And they'll start to show you a bunch of things that they might feel helps you. I want to give you 3 guidelines for non-traditional therapies or non-traditional medicines. In my opinion, number 1, it can't be too expensive. So if you have to mortgage your house to pay for it, something ain't right with that. Number 2, it can't be dangerous. And there are natural substances like arsenic that kill you. And so we want to make sure that the supplement or the thing that you're doing isn't dangerous or is not going to hurt you. And number 3 is, I don't think it should be done instead of something that we know works. I'll use an example of low-dose naltrexone. Low-dose naltrexone is very inexpensive and it's very safe. And if you tell me, Aaron, I want to take low-dose naltrexone in addition to my DMT, I'll say that's awesome. I think if you keep those guidelines in mind, they're a good mechanism to kind of help you as you learn about new and exciting and unstudied things.
So what Dr. Boster was talking about, low-dose naltrexone, most of you just know it as LDN. All right, so that way you know what he was talking about. And as far as Dr. Negroski eating mushrooms, he did not get that from his backyard. He was eating dinner in a restaurant. Great.
That's correct.
Correct. Megan, do you have anything to say about these alternative or therapies that people are hearing about on the internet and wanting to know more about, if they're safe or not for them?
What specific therapy do you?
Ganja.
So they were asking about lion's mane and mushrooms and CBDs and other things in that realm.
I don't know of any safe mushroom that would be available on the internet.
Okay, great.
There are certainly types of mushrooms that are safe to eat that have anti-inflammatory properties. Taki mushrooms, reishi mushrooms, those are safe to eat. But if someone's offering you mushrooms on the internet, I wouldn't buy them unless you're ready to go for a wild ride or a trip to the ER.
Right.
CBD oils, I couldn't quite hear. I think it was Dr. Boster that was talking. I couldn't quite hear everything that he was saying, but from the blips that I was hearing, I agree. CBD oils are not regulated, and so what you're getting may not be the same from, even if you're using the same brand, from batch to batch, and you don't know if that CBD oil is contaminated with anything that actually could be very harmful. I did some research this week for patients who had questions about CBD oil. I'm also in an integrative medicine fellowship at the University of Arizona that's very highly regarded, and there aren't really reputable brands out there yet that you can truly say to a person, if you go to this company, you're going to be getting an excellent form of a CBD oil. You also have to consider state-to-state regulations. CBD oils are not part of the, quote, medical marijuana prescription process, but there are rules that vary from state to state. So in general, I still think the area is a little bit uncharted and concerning from a safety standpoint.
Okay, thank you very much. Left side of the room, please.
Hi, good morning. If one has exacerbations and no new hyperintensities on MRIs, is it still recommended to go on steroids?
Yes.
Next question. He's short like that. Next question is over here.
Yes, this is for Dr. Bosner. Thank you so much, everybody, for the panel that you guys did. The question is about deciding between Lamtrona and Ocrevus. You know, you mentioned that with I started with Ocrevus just recently. Prior, I did Tysabri, and then they had to change because of the virus that increased, the number level increased. And I went to Tecfidera, and now I'm in Ocrevus. But after listening to you, Lamtrada, you are retraining your autoimmune system. How do you go about deciding which one is better?
So, in order to understand the answer, I typically review all of your MRIs from the time you were diagnosed until recent, meaning within the last couple months. And I do a neurological examination that takes about 15 minutes. I do a battery of validated questionnaires and several functional measures, and I spend an hour and a half talking to you. And after I've done that, I feel better informed to try to help be your partner in care. I can't answer that question for you without doing those things, or it wouldn't do you justice. But I think that that is a critical question, and you want to have it answered in partnership with your care provider. And I think it needs to be a conversation where you share your feelings and your opinions and what you learned, and then she shares her opinions and her feelings and what she's learned, and then together you make the best fit. There isn't an algorithm where A plus B equals C. This is very individualized because MS is individualized for every person. And the take home here is you have to talk to your provider and you have to form a team with them to grapple with these important decisions. I don't know if you want to add.
No, I'm in agreement. The shared decision-making process is key.
Question on the left?
Yes. Dr. Boster, I really miss being in Ohio and having you as my doctor.
OH.
I-O. Anyway, we moved to Florida within the past year to help take care of my mother-in-law, who was supposed to be coming home from a rehab and be as independent as she was before she went in the rehab. But we found ourselves in a very, very high-stress situation, and she's basically full-time care. So it's causing lots of stress for me because I'm having to change her diaper and things like that. So exciting. Anyway, I'm trying to find out one of the things that's happening that, I've always had tiredness, but one of the things that keeps happening is I will literally have days where I sleep from morning till night, and my husband will come in and he'll make sure I'm still breathing, and he'll ask if I need any pain medicine or anything like that. And it's all I can do to open my eyes to sit up and take some pain medicine or something like that. Is that would that be a direct result from stress? Because I can't even tell you how high the stress level is at this point.
So no one goes home at night and says, honey, let's get stressed out. That doesn't happen. And I firmly believe that psychosocial stressors can augment MS symptoms. The reality is that sometimes nature's a little too generous, and you can have multiple sclerosis and then have to do heroic things to help family and loved ones. And you don't get a break from either. And I hate it when doctors say, well, just remove the stress. I don't know how to do that. But I think you can learn to manage the stress. And one of the things that we don't do a very good job of in our culture is taking time for ourselves. There may need to be a discussion about every third day a caregiver comes in so that you can rest and you can recuperate. There may need to be a discussion about a different situation or environment that allows you as the caregiver to also be able to function.
I got you.
It's a very, very important thing. And I doubt that there's one element that's causing it. It's probably a multitude of things. I miss you, so come back and see me sometime.
Okay, before we continue with questions in the room, I do have to get one asked from the internet again. Again, for Dr. Boster, does stress cause MS lesions? Does sinus infections cause MS lesions?
So, there is evidence that infection can trigger an attack. So when you have an infection, your immune system gets revved up. Well, in MS, sometimes that can get too revved up. And so it is possible that an infection can trigger an attack. There's an ongoing debate amongst MSologists like us about whether or not psychosocial stressors can cause an attack. I'm of the opinion that in extreme circumstances, they probably can. But I can't prove that, and that's just my opinion. I think the jury is still out.
There was one study several years ago about the worst stress a person can have if you lose a child. And they looked at MS patients that have lost a child, and there was no increase in the level of exacerbations following that. And that was many years ago, and so things may have changed, but it's a tough situation.
Thank you. Right side.
I'm not sure who I should address this to, but I was diagnosed in '83 and I was having constant exacerbations. I was on steroids a lot, so I developed osteoporosis and I have 2 hip fractures. So finally in '93, I went on beta-seron for a while, and I haven't been on anything for like 10 years. And now my walking has gotten worse. I wanted to go on a Ocrevus or whatever, and I was told that I had to take steroids along with it, and I can't do that because of my hip fractures and osteoporosis that developed. So I'm wondering if there's any alternative besides steroids to take with.
So the Ocrevus steroid regimen is low dose methylprednisolone. It's 100 milligrams as opposed to the standard 1,000 milligrams 3 times every day for 3 days to 5 days for an exacerbation. So the reason for the 100 milligrams of IV steroids is to decrease the infusion reactions from the drug. So when you get the drug in, the way it works, it explodes these cells, these B cells. And when these cells are exploded, it releases all these weird substances in your body, which it can cause chills and infusion reactions. So to minimize that and mitigate it, they use low-dose steroids at the time of the infusion. So that may or may not be a contraindication to osteoporosis, but it's minimal amount.
Thank you. We have just about 6 minutes left, so we're only going to be able to take a few more questions, and we're going to go to the right side again. But for those that keep saying thank you, Stuart, it's not about me anymore. That was when it was Stu's Views. Now it's a village like these guys talk about. There's a lot of people involved with MS Views and News. So if anybody says anything, there's a lot of people behind every one of these programs. Okay, next. Where will we say? Right side, left side, right side.
Hey, Stu. What new medicines that have been coming from the other side of the world right now?
So the new drugs in the pipeline from other parts of the country, or the world, actually. So things have changed in the treatment of MS in terms of research studies. Years ago in the 90s, most of the patients that were enrolled in clinical trials were from the US. But now MS is obviously an international disease. These companies are international companies, and a lot of times we examine the same drugs that other countries examine. So a lot of the patients are enrolled from foreign countries, but it's the same drug that we're looking at in the US.
Great, thank you. Your side.
Hi there, this is for Dr. Boster and maybe the other panelists. But I was recently in October at a theme park, Universal Orlando, #called out, for Halloween Horror Nights. And I have been there about 7 times before with MS. I've been diagnosed about 10 years now. And I didn't get a pass where they can give you like a disability pass. They said that they recently changed their policy. I do know that they are still giving them out to people, but apparently they're very selective. And my question is what kind of, obviously because of the ADA Act, you can't really, they don't have to ask you for medical, like actual documentation. But what would your recommendation is to tell them? Because I feel prejudged because they basically looked at me and was like, oh, you look fine.
Honey, you look so good. Well, you look fine. And I think that happens all too often. I'm sorry you had that experience. That's terrible. What I would recommend, ask your care provider to write a letter on stationery from the hospital saying this patient is under my care. She suffers from X, Y, and Z because of this condition, and she needs to have accommodations when she attends this event. With any questions, please feel free to call me at this number. And I would go there with that letter so you can say, hey, this is from my doctor. There's been times that I've done that with patients, and that seemed to have helped in some situations. So that's an idea that you might consider.
Thank you. We have under 3 minutes left remaining. I do have to take one more from the field. This one, 30 seconds each. They want to hear from each of the speakers, all right? Megan, you're going to be first. What are your principal biomarkers for MS? 30 seconds. 25.
My principal biomarkers for MS?
Yes.
Oh, Lordy.
20 seconds remain for you.
A history and physical, an MRI, a vitamin D level, and smoking status. That's what I feel is the best thing that we have right now.
Thank you. Now you're challenging the other two to come up with something else.
So the biomarkers are basically, is there a blood test that you can do to diagnose MS or follow patients' response? Most recently, the biomarker that's out there is called neurofilament levels. So NFL, neurofilament light, is not the NFL football thing, but that's kind of the new biomarker that everyone's looking at as a potential help in MS patients.
Right now, we don't yet have the all-singing, all-knowing, all-dancing biomarker that tells us the answer. I think present day in clinical practice, the best biomarker is the MRI machine, but I agree with my colleague, the best information is from talking to the patient and examining them.
Thank you. Question over here, please.
Is it possible for lesions to form in the spinal cord before they form in the brain, or do they always start in the brain?
Yes.
That was quick. Left side of the room.
I wanted to tell you that about 3 weeks ago, my neurologist in St. Petersburg, he had me do a sleep study, and he says that I stopped breathing about 8 times. And so now I'm supposed to take a sleep apnea, because that's what he actually, he said I have to go put that thing in my face so I can actually breathe.
So obstructive sleep apnea is more prevalent in the MS population than we used to think. And obstructive sleep apnea makes it so that even though you're in bed and you're not awake, you're not getting restorative sleep. The number one symptom in MS is fatigue. And if you have MS and sleep apnea, you must treat the sleep apnea. Go back to the sleep doctor and say, the mask bothers me, give me another one. They have about 7 million different types of masks, and you may have to cycle through several before you find the right one, but it's critically important to manage your fatigue.
Last question is in the back of the room.
Yes, hi. I'm not sure if you can answer this, but I'm caregiver for my son who was diagnosed with MS 6 years ago. He was diagnosed with MS and atypical trigeminal neuralgia. So he's in constant pain 24/7. The last year's MRI showed no new scarring, no more lesions, no new lesions. However, his MS symptoms has gotten worse because of the pain medication he's on. We did try the gamma knife procedure, which left scarring, and he's not a candidate for a repeat gamma knife. What are your suggestions for him?
Medicine by Edison. And so there are pain stimulators that are typically used for lower back pain, but there are creative neurosurgeons around the world that can try to do pain modulation up in the head area as well. So looking into Medicine by Edison might be an example. I think getting a second opinion from a pain doctor. We have successfully treated trigeminal neuralgia with using pumps inside people's bodies. My point here is it's an extreme situation and you might need to look for answers outside of standard of care. I'm not talking about crazy wild things, but I'm talking about different types of modalities that you might not have tried yet.
Thank you for everybody and all your questions. Round of applause for all these great answers. And I have certificates to give to each of our presenters. Megan, I know you can't see what I'm doing here, but just know that you'll get something in the mail soon because it's a certificate of appreciation. We hope you'll put it up on the wall of your office. In the meantime, let me thank Dr. Negroski and Dr. Boster.
There we go.
Thank you. Great, thank you. So again, our thanks to these wonderful speakers, these wonderful physicians, and Megan, I'm glad that you were able to do this. Too bad we can't see the baby. Where's the baby? Is the baby sleeping? Megan, thank you very much for joining us today.
He's been nice and quiet.
All right, so a quick 3 minutes again. Megan, thank you very much. We're going to cut to another section right now, but we do want to thank you, okay? Again, thank you, everybody.